Welcome to this new episode. Today, we're diving deep into the neurodevelopment and growth of infants during their first year, a period that's truly unparalleled in terms of physical and neurological change. It's fascinating how much happens in just 12 months.
Absolutely. The infancy period is, without question, the most dynamic phase of human development. The rapidity and complexity of changes, both physical and neurological, are just staggering. And today, we're unpacking those milestones, the maturation of organ systems, psychosocial growth, and practical caregiving insights, all grounded in Canadian clinical standards.
Right, and I think it's important to start with the fundamental pattern of growth in infancy. The cephalocaudal and proximodistal sequences really set the stage. So, infants develop control starting from the head and trunk, then gradually extend that control outward to their limbs and fingers.
Yeah, that head-to-toe and center-to-periphery progression is key. It explains why head control precedes sitting, which in turn precedes crawling and walking. And it's reflected in the physical growth data too. For example, infants gain about 150 to 200 grams per week in the first 6 months, doubling their birth weight by around 5 to 6 months.
And by the end of the first year, that birth weight triples, averaging close to 9.75 kilograms. Height increases in spurts rather than a steady climb, about 2.5 centimeters per month in the first half year, then slowing down. The average length is roughly 65 centimeters at 6 months and 74 centimeters at 12 months.
The head circumference growth is equally impressive. It increases about 1.5 centimeters per month in the first 6 months, then slows to about half a centimeter monthly. By 1 year, the head size has grown by roughly a third, which mirrors the brain's rapid growth and differentiation.
Speaking of the brain, it's remarkable that brain weight approximately triples in that first year. That underpins the dramatic developmental achievements we see: primitive reflexes fading and voluntary, purposeful movements emerging.
Exactly, and the closure of cranial sutures follows a predictable timeline too. The posterior fontanelle closes by 6 to 8 weeks, while the anterior fontanelle closes between 12 and 18 months, averaging around 14 months.
The chest also undergoes notable changes. The lateral diameter becomes larger than the anteroposterior diameter, giving the chest a more adult-like contour. By the end of the first year, chest circumference roughly equals head circumference.
And the heart's growth is interesting. It doubles in weight by 1 year, but that's slower compared to the tripling of body weight. The heart remains relatively large in the chest cavity, with its width about 55% of the chest width.
That disproportion has implications for cardiovascular function and clinical assessments in infants. The heart rate slows during infancy, and sinus arrhythmia is common, where the rate increases with inspiration and decreases with expiration.
Blood pressure also changes dynamically. Systolic pressure rises in the first 2 months due to the left ventricle's increasing pumping ability, while diastolic pressure dips initially then gradually returns to near birth values. These fluctuations correspond with activity and emotional states.
Moving on to the respiratory system, the rate slows and stabilizes, but abdominal breathing persists. The anatomical features, like the short trachea and straight eustachian tubes, predispose infants to rapid spread of infections, such as otitis media.
Right, and the immune system is still maturing. Mucosal IgA is low in infancy, which reduces protection against infections. The infant relies heavily on maternal IgG for passive immunity during the first 3 months, after which the infant gradually synthesizes their own IgG, reaching about 40% of adult levels by 1 year.
That's a critical window of vulnerability, and hematopoiesis is also in flux. Fetal hemoglobin predominates for the first 5 months, but has a shorter lifespan, leading to physiological anemia between 3 and 6 months.
This anemia is normal and linked to decreased erythropoietin production and the depletion of maternal iron stores. Interestingly, delayed cord clamping at birth can mitigate this anemia by increasing the infant's blood volume.
The digestive system's immaturity is another important factor. Saliva secretion is minimal at birth, and coordinated swallowing develops around 3 months. Enzymatic digestion matures gradually. Amylase and lipase reach adult levels between 4 and 6 months, which aligns with the introduction of solid foods.
The liver remains immature throughout infancy, affecting bilirubin conjugation, gluconeogenesis, plasma protein formation, and vitamin storage. This immaturity explains why jaundice is common in newborns and why metabolic processes are still developing.
Thermoregulation improves as well. The skin's capillaries respond to temperature changes by constricting or dilating, and shivering develops as a heat-generating mechanism. Increased adipose tissue in the first 6 months also insulates the infant.
The renal system is immature too. The glomeruli filtration capacity is reduced, and full kidney maturity isn't reached until the latter half of the second year. Infants void frequently with low specific gravity urine, which predisposes them to dehydration.
Sensory development is fascinating. Auditory acuity is at adult levels during infancy, but visual acuity and binocular fixation develop by around 4 months. Depth perception emerges between 7 and 9 months, which likely serves as a safety mechanism.
That's a good point. The development of binocular vision and depth perception is crucial for motor skills and environmental interaction.
Speaking of motor skills, head control is a foundational milestone. Newborns have marked head lag when pulled to sitting, but by 3 months, head control improves significantly. By 4 to 6 months, head lag disappears, and infants can lift their head and chest about 90 degrees when prone.
There's a clinical alert here. If an infant still shows head lag at 6 months, a neurological evaluation is warranted. It's a red flag for developmental concerns.
Rolling over follows a predictable timeline too. Voluntary rolling from abdomen to back occurs around 5 months, and back to abdomen at 6 months. Importantly, prone sleeping increases the risk of sudden infant death syndrome, so supine sleep is recommended.
But supervised prone positioning while awake is beneficial for developing head control, crawling, and turning over.
Sitting develops progressively. The back's curvature evolves from uniform rounding to cervical and lumbar curves by 3 to 4 months. Infants can sit propped by 4 months, sit alone leaning on their hands by 7 months, and sit unsupported by 8 months.
Locomotion milestones include bearing weight on legs with assistance by 6 to 7 months, crawling on the belly, creeping on hands and knees by 9 months, pulling to stand and cruising by 9 to 11 months, and independent walking possibly by 12 months.
Another clinical alert: failure to pull to stand by 11 to 12 months should prompt evaluation for developmental dysplasia of the hip.
Fine motor skills evolve from reflexive palmar grasp to voluntary pincer grasp by 8 to 11 months. By 6 months, infants manipulate objects, hold bottles, and feed themselves simple foods. By 12 months, they may attempt to build block towers.
Shifting gears to psychosocial development, Erikson's stage of trust versus mistrust is central. Infants develop trust through consistent, responsive caregiving that meets their feeding, comfort, and stimulation needs.
Both over and under frustration can lead to mistrust. For example, if parents always meet needs before the infant signals readiness, the infant never learns to test control. Conversely, prolonged unmet needs cause frustration and mistrust.
Early social behaviors like grasping have powerful social meaning. Even reflexive grasping elicits reciprocal, tactile interaction from caregivers, reinforcing attachment.
Biting during teething introduces a conflict where infants learn control and boundaries. Caregiver responses, like saying no or offering substitutes, help resolve this and strengthen the mother-child relationship.
Piaget's sensorimotor phase from birth to 12 months includes 4 stages relevant here. The reflexive stage from birth to 1 month involves reflexes dominating behavior, with infants beginning to associate actions and outcomes.
Then, primary circular reactions from 1 to 4 months mark the start of voluntary acts replacing reflexes. Infants adapt to stimuli, like associating the parent's voice with feeding.
Secondary circular reactions from 4 to 8 months involve repetitive actions to elicit responses. Imitation and play emerge, and object permanence begins to develop.
The coordination of secondary schemata from 8 to 12 months sees infants solving simple problems, removing obstacles, and using symbols like waving bye-bye.
Object permanence is critical for attachment and separation anxiety development. Infants realize objects and people exist even when out of sight.
Body image develops alongside sensory motor skills. The mouth, hands, and feet are primary sources of pleasurable sensations. By 1 year, infants recognize themselves as distinct entities and often show fascination with mirrors.
Social development progresses from reflexive behaviors to interactive play. The social smile appears by 4 months, and games like peekaboo emerge between 6 and 12 months.
Stranger anxiety typically arises between 6 and 8 months, coinciding with selective attachment to caregivers.
Attachment develops in stages, from indiscriminate social responses in the first weeks to selective attachment by 6 months, extending to other family members thereafter.
Reactive attachment disorder is a serious consequence of disrupted attachment, with emotionally withdrawn and indiscriminate disinhibited patterns. Early intervention is crucial.
Separation anxiety emerges between 4 and 8 months, with predictable protest behaviors when caregivers leave.
Fear of strangers aligns with attachment development, with infants showing clinging, crying, and avoidance of unfamiliar people.
Language development starts with crying as the first communication, initially reflexive, then increasingly social. Crying peaks around 6 weeks and declines by 12 weeks.
Vocalizations progress from cooing and gurgling at 3 to 4 months to babbling and syllable repetition by 8 months. Meaningful words emerge around 10 to 12 months.
Infants comprehend simple commands like no by 9 to 10 months. Parental responsiveness is key for language acquisition.
Temperament influences parent-infant interactions and family dynamics. Screening tools like the Revised Infant Temperament Questionnaire help identify temperamental styles.
Temperament is biologically based, but modifiable by environment. Counseling parents on temperament can improve caregiving strategies and reduce conflict.
For example, difficult infants benefit from structured routines. Highly distractible infants may need extra soothing, and slow-to-warm-up infants require gradual exposure to new situations.
It's important to avoid negative labels and use descriptive, non-judgmental language when discussing temperament.
On practical caregiving, child care arrangements vary. In-home care, licensed family daycare, and center-based care. Licensing and regulation differ provincially.
Children in group care have higher rates of infections, but infection control education reduces risks. Parents should inquire about health and safety policies.
Discipline should match cognitive level. Time out can be adapted for infants, like using a playpen instead of a chair. Safety and consistent boundaries are essential.
Non-nutritive sucking is natural and beneficial, especially in preterm infants, improving weight gain and pain management.
Pacifier use is controversial. It may reduce SIDS risk but can be associated with decreased breastfeeding and increased otitis media if overused.
Recommendations include delaying pacifier introduction until breastfeeding is established and restricting use if recurrent ear infections occur.
Parents should be counseled on safe pacifier use and discouraged from modifying pacifiers.
Teething typically begins around 6 to 10 months, starting with lower central incisors. Symptoms include drooling, irritability, and biting.
Fever or diarrhea usually indicate illness, not teething, and warrant further evaluation.
Cold objects like frozen washcloths or teething rings soothe inflammation. Topical anesthetics carry risks and should be used cautiously.
Systemic analgesics like acetaminophen or ibuprofen may be used short-term. Teething powders, gum cutting, or aspirin application are discouraged due to safety concerns.
Regarding infant footwear, shoes should be flexible, soft, and protective, not rigid or hard-soled.
Proper fit is essential, with frequent size checks due to rapid foot growth. Shoes primarily protect feet. High tops aren't necessary for support.
Poorly fitting shoes can delay walking and cause foot deformities.
To sum up, the first year is a critical window for neurodevelopment, growth, and psychosocial formation. Understanding milestones allows early identification of delays.
Caregivers, responsiveness, consistency, and environment profoundly influence development. Clinical vigilance for signs like persistent head lag or attachment disturbances is vital.
Evidence-based guidance on caregiving practices supports optimal infant health and development. It's a complex but rewarding journey.
Thanks for joining this deep dive. Hopefully, this discussion enriches your understanding of infant development and informs your clinical practice.
Absolutely. Until next time,